this is meant to be kind of informal. So the idea is to go through the number one, kind of generally how to look at an angiogram, which I know in terms of imaging, we don't do a lot, especially at Memorial. There's not much angiography. So I hope to get you guys familiar with that, and then talk about intracranial vascular malformations, including arteriovenous malformations and AV fistulas, and hopefully by the end you know the difference between the two. And then kind of going over how we treat them, especially endovascularly, which is obviously what I do my fellowship in, which I think is the coolest thing we have in neurosurgery. So my disclosures for CME or whatever, I don't have any disclosures, and I describe off-label uses, which I will talk to you guys about. So summary, as I said, angiograms 101, and then AVMs. What are they? How do we grade them? How do we treat them? And Aruba, which doesn't make any sense, but will hopefully at the end, and then cases, and then the same thing with fistulas. So first of all, you suspect your patient has a problem with the blood vessel. What are the imaging modalities you can use for blood vessels? So there are three major ones. One is a CTA CTV, and that's really just a CAT scan of the head, and you inject contrast. And you take the pictures while the contrast is going through the arteries or the veins. So that's a CT arteriogram or a CTV venogram. The downsides to this are you have to give radiation and you have to give iodinated contrast, which can hit the kidneys, and also some people are allergic to. MRA, MRV is the magnetic, MR version of a CTA and CTV. The upside with this is that you can do these without contrast, and often you can do an MRA, MRV without contrast, except for very kind of specific indications. Almost always you order these without contrast, which is nice for patients that have bad kidneys or allergic, and patients you don't want to radiate like children. And then finally, there's diagnostic cerebral angiogram, DCA, or you might often see it with the abbreviation, the kind of old school abbreviation, which is digital subtraction angiogram, DSA. So this is kind of the gold standard to diagnose most lesions of the cerebral vasculature, including fistulas, aneurysms, et cetera. The downside is you get radiation and contrast, and usually more contrast than a CTA CTV. It's obviously invasive, and there's approximately, we quote patients, a 0.3 to 1% risk of complication. Complications from an angiogram can be stroke, dissection of a vessel, and injury to the access site. So, these days we're doing a lot of our angiograms through the wrist, radial access, but also through femoral access. So, overall for a young, healthy person, there's about a 0.3% risk of complication, up to 1% in an older person that has not healthy blood vessels. So this is what it actually looks like. This is like a stock photo, and no suite obviously is this clean, but just so you guys have an idea, because I know you guys don't often get to see these rooms. So this is what's called a biplane angiography machine. There's two X-rays. One, so the patient's head is like here, if you can imagine. This is, I guess, an anesthesiologist. Nobody ever actually stands there in real life. But the patient's head is here. There's one X-ray detector lateral and one X-ray detector AP, or on top of the patient's head, and so you take the pictures at the same time. So that's what biplane means. You're shooting both a lateral and an AP X-ray simultaneously. The operator stands here at the patient's either groin, which would be roughly here, or their wrist, which would be roughly here, and we watch on the TV screen as we're shooting the angiograms. So this is what's called a biplane suite. I think MSK has a single plane suite, which means it's just one of these detectors. They don't have both. The downside to it, it's a one plane, is that you have to, if you want an AP in the lateral, you have to shoot twice. So this is an example of a normal angiogram and how to think about a normal angiogram and the quote unquote phases of an angiogram. So on the left is an AP, you can see the patient's eyes, and then on the right is going to be a lateral. The patient's eyes are here. So this is just a normal shot. So this is going to be a internal carotid artery injection. So that's one, and this is what we see when we're shooting them in the Angio Suite too. And all these images get downloaded to PACS, and you can look at them when we do an angiogram on a patient. So the important thing to think about here is, so first of all, the reason it's called digital subtraction is you get an X-ray, and obviously bones show up on an X-ray. The machine digitally takes the bones and subtracts it out so that you get a very nice clear picture of the arteries. So the first step is you get a mask and then you subtract out, and this is obviously all done automatically, the bones. And then you see we inject into the artery. This is the internal cerebral artery, ICA. This is the MCA, this is the ACA, and this is the arterial phase. So this is the big arteries, big branches of the MCA. We let it go a little longer, and now it's in the arterial phase. These are the smaller vessels as you get into the capillaries, and then you get it a little longer, and this is the capillary phase. And this actually kind of this haziness, or like tiny, tiny blood vessels, which are actually perfusing the brain. And then you let it go a little longer, and this is the venous phase. So this is a very large vein. These are some veins here. And then eventually the sinuses of the brain start filling. So this is the superior sagittal sinus, and these are the transverse sinuses. And you can see the same thing on the lateral. Arterial phase, arterial phase, capillary phase, and then venous phase. There's that large vein, and the transverse sinus is filling here, and the superior sagittal sinus is filling. So this is another example. This is an injection of the vertebral artery. Same thing, arterial phase, and then now the venous phase, and you can see the sinuses start to fill. And this is it, the same thing in lateral. This is the vertebral artery. So as you can see, the advantages of an invasive angiogram over non-invasive imaging is you can see actual blood flow, and you can see how it transitions from all the phases. And that's extremely important for what we're talking about today, which are arteriovenous malformations of the brain, which is when that orderly transition from artery phase to arterial phase to capillary phase to venous phase doesn't work properly, and that can cause the patient problems. So the first example of this we're going to talk about is an arteriovenous malformation, and this is kind of a drawing which I like. So this is, again, if you think back at that angiogram, this is what I was going through. So large artery, and then arterioles, and then capillaries. Oxygenated blood goes, the tissues extract the oxygen, and then it becomes venous blood, and then it goes backwards into venules and then large veins. This is normal. This is how it's supposed to look. In AVM is basically where you have a connection between arteries and veins that skips the capillary phase, and it can cause these abnormal tangles of vessels. And why this is a problem is because, as you go through capillaries, the pressure naturally decreases until you get to the vein. And obviously veins are much, much lower pressure than arteries. In this scenario, you have veins that are seeing arterial pressure. So there's arterial pressure in veins, which are just not built to see that kind of pressure. And that's why these AVMs can often bleed and rupture and cause problems. So AVMs in general, or as I just said, abnormal direct connection of an artery to a vein with an intraparenchymal nidus, which I'll show you pictures of in a minute. They carry about a 2.2% risk of rupture per year, with a 10 to 15% mortality rate with rupture, and then a 30 to 50% chance of having a major deficit with rupture. These things are rare. It's about 10 per 100,000 people, 3,000 new cases in a year per year in the United States. It's roughly the same incidence. It's on the same order of magnitude as like a GBM. GBM is a little bit more common than AVM, but they're like, on the same general plane. So they can present with deficit seizures, epilepsy, or hemorrhage, and it's typically a disease of young people. So we think of these things as they develop in, even prenatally. So you've had them your whole life, and then you come to attention when they rupture or they cause bleeding. And so the mean age of diagnosis is between 20 and 30 years old. So if you have a patient, in the emergency room or in the ICU, and they're a young 20 to 30-year-old and they have a hemorrhage in their brain, it's the first thing you should think about is an AVM that ruptured when you're working that patient up. These are just some examples. So you can actually often see AVMs on you don't even need a specialty MRA, MRB. You can usually see them just on an MRI. This is a T2 MRI. You can see this abnormal tangle of vessels, and you can see this giant draining abnormal vein into the straight sinus. So this is an example of an AVM just on a normal MRI. This is what the AVM looks like on an angiogram. We'll look at other pictures too. So the red are the feeding arteries, the yellow arrows are the nidus, and then the blue arrows are the abnormal draining veins. So these are just two examples of what they look like on an angiogram. And you can see why going through the phases is important, because here you can see that this is clearly the arterial phase, but you already have filling of a vein, which suggests that the vein is filling very early, and that's an abnormal connection between an artery and a vein. Usually you don't see these veins start filling until all this arterial contrast is washed out. And then this is what it looks like in the operating room. This is, again, that abnormal tangled vessels. It looks just like that drawing. And then this is kind of a giant abnormal vein that's draining. Here's another abnormal vein that's draining. So if you have one of these, how do you manage them and how do you treat them? So there's two kind of flavors of AVM. There's a ruptured AVM, which is obviously someone that had a bleed, which we can talk about. And then there's unruptured, which is very controversial right now, how to treat these. So we'll talk about unruptured in a second. Nowadays, everyone is getting an MRI of their brain for various reasons, and sometimes you find these AVMs that are completely unruptured, and there's controversy how to treat them. Treatment options are radiation works better on smaller AVMs, and there's a lag time between radiation and the AVM actually shrinking. So at 2 years, you have an 80 to 90% control rate of AVMs for AVMs that are smaller than 2 centimeters, but it's down to 40 to 50% for large AVMs. And again, it takes 2 years. So you're kind of quote unquote unprotected for 2 years while you're waiting for the radiation to work. Embolization, which we do in INR, which involves threading a small catheter up to the AVM and injecting glue into the AVM. We do that often before surgery. We rarely do it by itself. So you often do embolization and surgery. And then you could do surgery, which cures it. You literally cut it out and you cure the AVM, but that comes with the risk of surgery. If you have a ruptured AVM, these patients will almost always go to the ICU for strict blood pressure control, manage their intracranial pressures if they're having a large bleed, and then if they're having seizures, which is a very common presentation, you manage all that medically. There's almost never an indication to go in and take this out acutely. So if you have an AVM that bleeds, the last thing you want to do is rush into the operating room, because the brain is, we say that it's angry. Everything's swollen and it's a huge mess, and there could be bleeding that you can't control. So the thing to do for a patient that comes in with a ruptured AVM is you do an angiogram that confirms the diagnosis of an AVM, and then also if you see something, a high risk feature of the AVM, then you can treat the high risk feature. And what that I mean is sometimes the flow is so high to these AVMs that they develop aneurysms, and the aneurysms rupture. If you see an aneurysm associated with an AVM, you should treat that right away, just like if you see an aneurysm in a subarachnoid hemorrhage patient. But you shouldn't rush in and try to treat the entire AVM. You just treat it if there's a high risk feature, if you can identify a high risk feature. Otherwise, you manage them medically, and then you take them to fix the AVM in the future after the kind of acute phase is over. So this is Aruba, and this is the Aruba trial, which neurosurgeons hate. This is an extremely flawed, problematic trial that came out about 7-8 years ago. It's a randomized trial of 200 patients. It was published in Lancet, which is obviously a very elite, highly regarded journal. And generally their conclusion was that patients that were followed medically had superior outcomes to intervention groups. So this is how to treat AVMs that are unruptured. And they found that if you just follow them and control their blood pressure, they do better than if you try to treat them. And so the argument that these authors were trying to make was that if you have an unruptured AVM, you shouldn't treat it. Unfortunately, this is an extremely flawed trial, especially because the intervention group included every kind of intervention, surgery, radiation, embolization. It was not standardized in any way. Essentially, this trial was not standardized in any way. And so, and a lot of these patients had surgery and procedures at centers that don't do a high number of these procedures. So obviously they had bad outcomes. So, when you're trying to decide for a patient if they should have an unruptured AVM treated, just know that every year they have a 2% chance of it bleeding. And if it bleeds, they have a 10% chance of dying. So that's the fact. So if someone in an older patient, in an 80-year-old, it might make sense to not treat them. In someone that's 20 years old, they have probably 80 years of life left. And every year they have a 2% chance of having a catastrophic hemorrhage. So, as neurosurgeons, we say if we think it's safe to treat, which is a different conversation, then it should be treated. And of course, this trial is going to be repeated because, again, a lot of people weren't happy with it. So now that you know what an AVM is, how do we grade them and how do we talk about them? So the classic grading scale that, if we're signing out an AVM patient to the ICU, we often will report the grade. It's called the Spetzer-Martin scale. Dr. Spetzer is a very famous vascular neurosurgeon. who made his career on AVMs. And he essentially came up with this grading scale. And so there's 3 things that go into it. It's the size, small, medium, large. The cutoffs are 3 and 6 centimeters. Eloquence of adjacent brain, which just means, is it in the motor strip or is it in the sensory strip? Is it in places of the brain that have a clear function, and therefore would doing surgery on this location cause the patient to have a deficit? And then venous drainage. So he makes a difference between superficial or deep venous drainage. And obviously deep draining AVMs are more risky to treat. So if we go back to this MRI, using that grading scale, this is roughly 3 to 6 centimeters. I don't know the exact number, so that would get it a 2. This giant vein is draining into the straight sinus, which is a deep vein, so they get a point for that. And it's sitting in the thalamus, which is an eloquent brain structure, so we get a point for that. So this is a Spetzler-Martin 4 AVM, which is considered a high-grade AVM. What does the grading scale tell you? The grading scale tells you how you're going to do if you have surgery for this. Spetzler-Martin grade 1 and 2, you do pretty well. 95% of people don't have deficits, all the way down to grade 5, which is, essentially there's a high chance that you're gonna come out with a deficit. And then the other very important thing to note about the Spetzler-Martin grading scale is this is if Spetzler operates on you, because it's his series. So these numbers are much, much higher in the hands of a less experienced surgeon. So typically we say Spetzler-Martin grades 1 and 2 should be operated on. 3 is kind of combination operation, radiation, surgery. And then 4s and 5s, you need to really think about what the risks versus benefits are of operating on a patient with a high grade AVM. So this is a case. This is an actual case that was at Cornell a couple months ago. Before I go into the cases, does anyone have any questions? Okay, type any if you have them. Is there a genetic component in AVMs? Nobody really knows. There are some genetic syndromes where you get AVMs kind of all over your whole body. Like you get AVMs in your lungs and in other organs, including the brain. So there's a genetic component to that. In terms of a genetic component to like isolated cerebral AVMs, there's not anything that I know of. So 28-year-old woman. Oh yeah, go back to the grading scale. Yes. So it's really just size, where it is sitting in the brain, and the drainage. Which, by the way, for the venous drainage part, you really need to actually have an angiogram. You can usually tell on an MRA, but you really need an angiogram to know for sure where the drainage is. And then the eloquence and the size, you can measure that on an MRI. So 28-year-old lady, she's a highly functional, she's a graduate student. And she had a subacute onset of intermittent sensory symptoms, headaches, and brief periods of confusion. So we're thinking that this lady is having seizures. And so she, as a workup for seizures in a 28-year-old, got a brain MRI, looked like this. So I'll go through it again. So here's what's interesting. So you can see these kind of dots and flow voids. So in a T2 MRI, anything that's black like this usually means that there's blood flowing through it. So you can see all these this kind of cluster of abnormal dots, and then this giant, big kind of vein. So this is an AVM. There's no evidence that it bled. You would see signal if there was blood, and the brain around it would usually have some signal which implies that it's angry or has some edema. So there's no evidence that this thing bled, but AVMs, unruptured AVMs, can cause seizures or epilepsy. It's pretty small. This is probably less than 3 centimeters. It looks like there's only one big vein and it's draining superficially, so not deep draining. But unfortunately for her, this is the location of it. So this is motor and this is sensory. So she's right in the middle of her extremely eloquent cortex. So it's the motory sensory strip. So she gets 1 point for 1 point for size and 1 point for eloquent cortex. This is Spetzel Martin 2, which you know, makes her a reasonable surgical candidate, except for the fact that it's really literally sitting right in the middle of a very eloquent brain. And so considering that she was having seizures, so this is her angiogram. So remember the phases. So this is arterial phase. And already late arterial phase, you're seeing this giant vein filling in this abnormal tangle of vessels. So this is a arteriovenous malformation. And then you can see the giant vein and then it drains into the sinus. This is the lateral. So she has this AVM, which we saw in the non-invasive imaging. So considering the fact that she was having seizures and the fact that she wasn't really a great surgical candidate because of its location, she underwent SRS. And then she returned 6 months later with an episode of unconsciousness and right-sided weakness. So obviously we're thinking about seizure again. She got a head CT. And you could see that bleeding. Right there, small focus of blood. And now, unlike the MRI, there's some edema around it too. So this is a new bleed. And it makes sense. She had a bleed because she was having seizures because she had a bleed, something changed. And so she came in with a ruptured AVM and we did an angiogram. And so this is the same. This is a little bit zoomed in, but this is, you know, we're looking for changes to see if the AVM changed at all. And you can see right here that there's something that was not there on the first angiogram, which is this little guy. So that's a new aneurysm in the AVM. And if you kind of line this up with her CAT scan, it's exactly where her bleeding was. So we had to treat that. So I don't know if you can appreciate here. So this is our catheter. So this is like how we actually do these procedures. You can trace it. This is our microcatheter and it's going in the blood vessels all the way around, loop to loop, all the way up to here. That's the tip of our microcatheter. We thread it all the way up there. We do an injection. You can see we're right there where the aneurysm is. And then if you look here, kind of use your imagination, you can see this kind of dark staining here. So we injected glue into the aneurysm and then we do a run afterwards and the aneurysm is gone. It used to be right here, it's gone. So that's how she was treated. So that's AVMs. I'm going to go into fistulas unless anyone has any questions. These are going to be a little faster because they're a lot more rare. But they're a lot.
I have a question.
Yes,
Alex.
Yes.
If you do have a cerebral AVM,
yeah,
like, what are the chances of you having more? Is it like an aneurysm where sometimes you have one, you have multiple, or is an AVM kind of like a one and done thing?
Usually you have one. So there's some people that have like very large, diffuse, huge AVMs, which and that's a little bit different. You know, a diffuse AVM versus a very compact. The ones that I've shown are very compact nitises. Some people have very diffuse AVMs. So that's not like, it's possible if they had multiple AVMs that kind of merge into one large one, but generally if you have one like compact nidus AVM, you usually just have the one. Again, unless you have one of these rare genetic syndromes where you have AVMs kind of all over your body and then anything goes. But just an isolated single AVM, usually you just have the one. And usually if they recur, recurrence is very rare, but sometimes it happens. If they recur around the same place. They don't recur somewhere else. Oh yeah, those are great questions. So the question was why we treated that intranidal AVM, that intranidal aneurysm with glue rather than a coil. So the reason we don't usually glue aneurysms in general is because we don't want the glue to fly into like Precious brain. For the AVM, we got our catheter way far out, just basically into the nidus. So if we shot glue there, the only thing it was going to shoot into was the nidus, which is, so we know that it's relatively safe to give glue there, number one. And number two, you have to have a certain size of catheter to take a coil, and the size of the catheter that we had to bring out way out that distally, you can't fit a coil inside a catheter that small. So that's why we use glue. Number one, because it's safe, and number two, because we needed to use this specialized, very tiny catheter to get far out there. High risk in specific patient populations. That's a good question. I think, people try to figure out what makes you at high risk for rupture. The things that definitely make you high risk for rupture is an intranidal aneurysm or a venous outflow obstruction. And then there's like very conflicting data about, like, some people say that smaller AVMs are actually more likely to rupture because they're higher pressure, the nidus is smaller. Some people say larger AVMs are more likely to rupture, so it's like kind of unclear. So the only thing that we know for sure is if you have an intranidal aneurysm or if you have a venous outflow obstruction, which means that basically that draining vein, that big kind of plump draining vein that I've been showing you in all these pictures, if it's very stenotic, then you're at high risk to rupture. So it's really just based on the architecture of the AVM, more than anything about the patient themselves. Obviously, if you have high blood pressure, you're more likely to rupture an AVM. Anything that would increase the pressure in the head. All right, so derivative fistula, this is just kind of for fun because these are super rare lesions, but they're my favorite thing to treat. So I wanted to talk about them a little bit. So this is an abnormal connection between an artery and a dural venous sinus or a subarachnoid vein. So there's no like intraparenchymal nidus. It's just a connection directly between the artery and a vein. It's usually feeders from the external carotid artery. And then the classic thing, like this is a classic boards question for us, but you might see a patient in clinic or in the hospital, is pulsatile tinnitus, which is specifically tinnitus. So tinnitus is like ringing in the ear. It's ringing in the ear that comes with the heartbeat. So they'll often describe either ringing in the ear that comes with every heartbeat or like a whooshing sound. So it's like, whoosh, whoosh, and it's perfectly in sync with their heartbeat. That's like classic AV fistula until proven otherwise. The risk factors for this, they're often spontaneous, but they could be caused by trauma or venous thrombosis. They're approximately 10 times more rare than AVMs. And again, there's no parenchymal nidus. So this is kind of how to conceptualize them. This is an artery directly connecting into a sinus. This is a low-grade fistula. The Borden classification is what we use to classify fistulas, 1, 2, and 3. Don't worry about Conyard, that's a little complicated. I like Borden because it's simple and makes sense. So this is artery connecting to a sinus, and it's draining in the correct direction. So the sinus drains from the brain to the heart. So it's an artery connected to a sinus and it's draining in the right direction. Type 2 is an artery draining into a sinus and it's going backwards. So it's going away from the heart and it's flowing into cerebral veins, which is obviously, again, veins are not used to seeing high pressure. So if veins see high pressure, they're at a high risk for rupture. And then the most dangerous kind of all is where you have an artery connecting directly into a vein without even involving the sinus. So the artery and the vein are just directly connected, which obviously, again, puts these thin-walled veins, which are not used to seeing high pressure, under extremely high pressure, and they're at a risk for rupturing. And as you would expect, kind of a Borden type 1, sorry, this is a little bit of a busy chart, but the Borden type 1 have an extremely low risk of rupturing, less than 1%. So essentially 0 and a 0% death risk. The Borden type 3s are extremely high risk for rupture. And if they've ruptured once before, there's even higher risk that they'll rupture again. So we typically recommend treatment for Borden type 3, no matter what the symptoms are. We recommend treatment for low-grade fistulas if the pulsatile tinnitus is very distressing to the patient. And some patients have it bothers them a lot and it drives them crazy. And if you treat the fistula, you just decrease flow through the fistula, they actually do get better and their pulsatile tinnitus goes away. So again, we recommend low-grade treatment for patients that have distressing symptoms, and then high-grade treatment in kind of everybody to reduce the risk of bleeding. There's 4 treatment options: radiation, which is, again, because these are so rare, it's not done that much, but you could do it. Open surgery, transarterial embolization, and transvenous embolization. So unlike for AVMs, which you can't really embolize through the venous side, you can go in and actually you can find the vein for a fistula, and you can shut down the vein. And I'll show an example what that looks like. So this is what a fistula looks like. This is before any treatment. So this is an external carotid artery run, and you can see that. Good. You can see that it's filling up the sinus, and it's flowing in the wrong direction, right? So the blood is going, I'll play it again, but the blood is going from the fistula backwards towards the brain, not towards the heart, which is this way. So one more time. So it's, the sinus is flowing backwards. So that's what we mean by retrograde flow. This is after we treat it. So this is our little catheter. We inject a glue-like substance called onyx. I'm required to say this is technically an off-label use of onyx because fistulas are very rare and onyx is only approved for AVMs. And so you can see if you can push the glue and it fills up all the fistula's connections. And we thought we did a pretty good job. But then this is injecting contrast after. And you can see that the flow is definitely slower through the vein, and you can see that it's kind of hanging out there. So we've definitely slowed it down, but we didn't completely kill it. And this guy had really bad pulsatile tenderness, and we wanted to cure him to make him feel better. So then we went into the actual sinus, and we put tons of coils in the sinus and just completely shut the sinus down. So that would be that's a transvenous treatment. And so this is after that. So you can see no fistula, and you can see, pause it here. This is the superior sagittal sinus, this is the transverse sinus on the left in the jugular vein. So that's all filling. And on the right, it's completely gone because we killed it with coils. And this is the lateral, same thing. And so there's no more fistula. Does anyone have any questions about fistulas? Yeah, so if you shut down the sinus, you put in risk for an ICH. That's a great question. So the thing so you can't shut down the sinus for everybody. You can only shut down the sinus for people that aren't using the sinus, where their normal brain isn't using the sinus. So what I didn't show this part, but what you always have to check is you just do an angiogram of their brain, and you see where the blood is, where the normal venous blood is flowing. And in patients with high-grade fistulas like this guy, the fistula basically, we say that it hijacked the sinus. So the only thing that the sinus was draining was the fistula. So the fistula, the sinus was not draining normal brain. So in that instance, it's safe because you have two sinuses, you have a left and a right sinus. So you can take the right sinus if your normal brain is not using the sinus. And again, in the case of the guy that I just showed, he wasn't using the sinus. The fistula just took over completely. So we killed the sinus. But yeah, otherwise, if you take down the sinus in a healthy in a person that doesn't have this problem, then you could definitely cause them to have a venous stroke for sure. And it's a risk. It's a risk with transvenous embolization, which is why we don't do it unless we have to. So this is another case. This was from a couple of years ago. This is essentially a guy that had an angiogram because he came in and said that he had an aneurysm. So we just did an angiogram to see if he had an aneurysm, and he didn't. But he had an abnormal connection. It's not very clear on the AP, but see if you can find it on the lateral. So I'll put it again, it's going to be right here. So there's an abnormal connection, and this actually is a vein. So you see this abnormal connection and then a vein draining, and you can tell it's a vein because it's going up and then draining to superior sagittal sinus. So that's why really it's very important that you do actually angiograms on these patients, especially for fistulas, because they can be subtle and you need to see the direction of the flow. So this is a still image of that angiogram, and this is the target here. So this is a abnormal connection directly into a vein. So this is a Borden type 3 fistula, which we would definitely recommend this eye is treated because again, this vein should not be seeing arterialized flow, and he's at high risk for rupture. So we did the same trick. We gave onyx. We did a post-embolization angiogram, It was here, remember? It's gone. We're pretty happy about that. We brought him back in 10 months. We did another angiogram. And he recurred. It's very frustrating. Here's that vein. It's back. So we gave him more glue. You can see here. And despite that, we weren't able to fully kill it. And I'll say that going transvenous on such a small cortical vein, this isn't like taking down the sinus, which is a very large thing that's easy to take down. Going transvenous on a small cortical vein is very dangerous. So we decided not to do that. And we did open surgery. So this is going down. This is obviously normal brain. This is that artery. So, or the vein, excuse me. This is the abnormal vein, and you can tell it's halfway between an artery and a vein. A vein is usually very purple, and an artery is very red, and this is kind of halfway. So this is what we call an arterialized vein. This is the abnormal vein. This color does not ever occur in nature. This is actually what onyx looks like from the outside. So this is a vessel that had that glue injected in it, and that's what it looks like. So we were here before we injected some glue. We just weren't able to take it all down, and then we were able to isolate this vein. And then you just come across it and you cauterize it and you cut it, and the fistula is cured. We have the ability to do angiograms inside the OR. So this is what it looked like after we did that. Remember, the abnormal vein was around here somewhere, and it's all gone. So that's how we treated that guy. That guy got kind of the full treatment. He got open surgery and embolization. So that's the last case I have. So that was AVMs and AV fistulas. I'm happy to take any questions, and I'm happy to also, if anyone ever wants to come down to INR and watch us do these cases, we're happy to have you anytime.
Everyone here just said they want to come, Alex.
You guys should come. So questions. Interrupt clipping. So for a clipping is like for an aneurysm. We'll clip an aneurysm for these fistulas. You just cut. You just usually cut it. Presenting, yeah. So for AV fistulas can present like, again, the pulsatile tendinous is very classic. Generalized headache. So if you have venous, especially if you have the situation where you're draining into a sinus and you're causing the veins to become engorged with arterial blood, you have venous hypertension, and venous hypertension can cause headaches for sure. But could also cause, eventually if the brain that's affected has so much venous hypertension, you could start to get deficits and seizures and stuff like that. So that's a more rare presentation of fistulas, but definitely possible. And then of course, anyone with a dural AV fistula can have a bleed. So that's also a possibility.
Okay, any more questions?